MRI safety is at the forefront of our profession. It starts with protecting Zone 4 and is why the ACR recommends using a caution barrier at the Zone 4 entrance. But what good is another sign in a room full of signs? Well, Aegis has created the perfect solution with TechGate Auto. TechGate Auto allows more focus on the patient and less worries about someone entering the room without being cleared. If you're serious about MRI safety, use the link in the description below to find out more.
Zone 3 podcast. Robert here. I got Reggie. We're the MRI guys. We're lucky enough to be joined by the cardiac guys. We've got Dr. Jokerst closest to the camera here, and we've got Dr. Marcotte. We got a radiologist and a cardiologist, and today we're discussing cardiac MRIs.
Right. Some really special guest today. We appreciate you guys coming to visit us.
Thanks for having us.
Wow. Yeah, we're lucky enough to be joined by some of the best in the industry. So today...
Very modest too. Very modest.
I like that. So if you would, Dr. Jokerst, just kind of describe your background, some of your hobbies, maybe outside
a little bit
of
about
work.
Yourself for sure.
Sure. So, I'm from the Midwest originally, a little town about an hour south of St. Louis. Grew up, spent a lot of time outdoors, did all my training in St. Louis, went to medical school there. Residency in diagnostic radiology, fellowship in cardiothoracic imaging at, can I mention the institution?
Sure.
Washington University there in St. Louis.
Nice.
Yeah. And, came out to Arizona.
Got hot?
Gosh, it's been about 7 years ago, 2013 when I came out here. So I've been attending now for about 7 years, and do cardiothoracic imaging, and lately I've gotten a little more interested in kind of the physics and technical aspects of MR. But
wow, nice.
Yep. So that's a little bit about me. Anything else you guys want to know?
Well, we're lucky to have you in Arizona.
For sure.
Working in the same hospital as us.
Not missing the winter.
So you were probably one of the first res that I witnessed actually jump on the scanner and really knew what you were manipulating, and just click, 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 click.
I will say that's,
I was really impressed.
You're like House.
Yeah.
Exactly. Right?
Just like Hollywood right here.
They're all scanning and doing surgery and all that kind of stuff. But my fellowship emphasized that a lot, and I'm glad it did because it's helpful. So.
Oh, for sure. I know it helps us out a lot too, that you can actually break down where to go to make some of the changes that you're requesting or some of the things that, you want us to do for you. So, I really appreciate that. That's nice.
You're sweet.
And we also really appreciate Dr. Marcotte.
Yes.
So Dr. Marcotte, if you would, tell us about yourself, your background.
I am François Marcotte. I'm originally from Montreal. Did my med school at University of Montreal, and then the residency at McGill University, and then fellowships at the University of Toronto.
Nice.
I'm a cardiologist who specializes in congenital heart defects, which is people born with heart defects.
Nice.
Blue babies and the unfortunate and non-invasive imaging. And I've focused on imaging that doesn't require x-rays. So I started with ultrasound, and then I saw some of the limitations of ultrasound, and then became interested in MRI, and then learned about that, and I've used it ever since. I've been doing MRI for about 20 years, and I really enjoy it. I think it's a great complement to my practice. I think it can bring a lot to the table.
All right.
So glad to be here.
And Francois has brought a lot to the table. I got to say, reading cases with him has been, one of the highlighds of the last few years. So it's a real pleasure.
Has it made you step your game up a little bit?
Absolutely. I remember when he was coming, I was reading books and trying to because I didn't want to be a backwoods yokel. So.
Awesome.
I think our collaboration exemplifies the importance of collaboration, and the fact that we each have our strengths. For me, there's stuff that I feel less comfortable reading, like, chronic aortic syndromes or stuff that's in the lungs or mediastinum and stuff like that. And I learn a lot from Clint and our other radiologists. So it's really, I learn a lot. I can tell you, I'm really happy.
Nice. It's pretty cool.
Well, it's because you guys are happy to share your knowledge, and that's one of the reasons why we brought you here, because, I've worked with a lot of radiologists and not very many cardiologists, but you guys are awesome to work with. So thank you.
Yeah.
Thank you.
Thank you for being here today. Appreciate it. So we kind of want to dive into it. We don't really know the direction because really you're the experts on today's subject. So we'll kind of follow the guidelines, but we kind of wanted to go over anatomy. We wanted to go over physiology. We wanted to go over pathology as well. So you mentioned earlier that originally you started it with ultrasound as being your diagnostic imaging go-to. I'm curious about how that compares to, like, say, a HIDA scan, which is usually in conjunction with an ultrasound, like a stress test.
Yes.
How those two would compare, like an MR, as far as information provided.
Yeah. I mean, did we want to go to the second slide? Maybe we could I have a comparative note here.
So Dr. Marcotte, we love prepared guests, so thank you. we love unprepared guests, so thank you too. So
cardiologists who see patients with heart disease are faced with, the nice thing about cardiology, there's a fairly limited number of clinical problems people have. They're short of breath, they have chest pain,
right,
they have palpitations, they pass out, or they have swelling, or and then so we have a number of tests, and typically as a first line test we'll do chest x-ray, EKG, an echocardiogram, but some of the limitations we have with echo is the what we call the spatial resolution, the ability to see small things.
Right.
This is a slide that shows the various capabilities you were talking about, scans and stuff like that. So echo has a very high temporal resolution, which means it's very quick. It's got a high frame rate. So you can see small things, medium to small things that move quickly, like valves. Mm-hmm. It's very good to record velocity, like Doppler and that type of thing. But it doesn't see well, for example, if there's air, if there's bone, a lot of fat. So we're limited in terms of the ability to penetrate some of these structures in the chest, especially.
Right.
Now we're lucky because the heart's kind of midline. We can finagle our way between the ribs to see the heart. Mm-hmm. But that's one of the things that CT does. And Clint, I don't do any CT, but Clint does CT.
Yeah, I can.
And
expand on that.
CT's got a fantastic spatial resolution. It's under a millimeter.
Yeah.
That's something I wanted to touch up on today, was just the difference in the modalities and what value each one brings, and what's your preference for sure. You mentioned a radiograph or chest x-ray, but I'm thinking, like, in my experience as an x-ray tech, beyond CHF or some sort of abnormality within the size of itself. I mean, like you wouldn't be able to diagnose an infarct or something like that.
No, you'd need an EKG, an echo.
Okay.
And the thing, if I carry on, so CT has very good spatial resolution. In terms of temporal resolution, it's the opposite of echo. So it doesn't have a high frame rate, but there are improvements, and Clint can talk more about that.
Yeah.
The nice thing about MRI is just in the middle. So it's got the best of both, and that's why I put it right in the middle.
Nice.
So it doesn't have quite the frame rate that echo has, but it's got a better frame rate than CT.
Right.
It's got a spatial resolution that's better than echo, but unfortunately not as good as CT. The good thing is that it doesn't expose the patient to radiation like CT and nuclear medicine do. And really the hidden gem is that the fact that we do nice pictures of anatomy, but really, if you look at MRI, it's been invented as a tool to analyze tissue. So it's like a histochemical analysis.
Right.
You generate great pictures, but you can tell whether you're dealing with fat, with blood, with muscle, with et cetera. So it brings to the table the whole concept of tissue characterization, which is kind of more difficult with echo. We do have a sense, we can see if something's cystic or solid, but there's once it's solid, then you can get a lot more information. I don't know about CT, Clint.
The way I like to think about it is, echo and CT are kind of sort of one-trick ponies. So if you think about it, what are you doing with echo? You're imaging sound waves.
Right.
That's all you're doing. There's nothing else you can do with echo.
Right.
CT is the same thing. What are you doing? You're blasting somebody with photons. Right. Some of the photons are going through and some are stopping. So you're imaging how tissue attenuates photons. You can change the profile by giving somebody contrast, with iodine or barium or what. But at the end of the day, you're just looking at one thing, basically. Whereas with MRI, you can make all these little tweaks and adjustments. And like Francois was saying, really characterize tissue, but it can do so much more. And just another kind of plus of MR, I think, echo is great. It's widely available. It doesn't require any ionizing radiation. There's no dangerous magnetic fields. It's definitely first line when we're looking at the heart for a lot of different conditions. The echo is very operator dependent, and it's kind of like, the way I like to think of it is, imagine you're going into a dark room, and you kind of know where to look in the dark room, and you have a flashlight, and you're looking around in that dark room.
Oh, I like that. Yeah.
Yeah, MRI is basically turning on the overhead light and, illuminating the entire room.
That's
so
awesome.
you don't have to spend as... Now, that being said, of course, if the echo probe is in the hands of an accomplished sonographer, it's not a big deal because they know where to shine the light. But,
Right.
Not everybody is, Vincent Van Gogh of...
Although when we say technical dependence, and I think you're right about that for echo, it's also you need technical expertise to do MRI. It's probably one of the most difficult MRI, or one of the most challenging types of MRI. Even though the vendors are trying to put some very automated protocols and help you with defining planes and stuff. It requires a lot more hands-on than, I'm from an era, and I guess you might be as well. But so when initially we didn't have all these tools, so the technologists had to know the anatomy, know where to cut. So we had some set protocols. And the thing with the heart is that unlike most static organs, it earns its living by moving constantly. Right. So as you know, in MRI, moving constantly is like
that's an issue, right?
Exactly.
Stop. And if that weren't hard enough, the lungs also move. Right? So you introduce breathing motion. So we thus have to rely on sequences that are very fast. And we have to rely a lot on breath holding to sort of stabilize, to limit the variables to simply the heart moving. And then a lot of the sequences we use are called segmented sequences, where we chop the cardiac. Everything's gated, so we chop off the cardiac cycle to get our images and get all these phases with the best possible resolution. So you see, it's kind of a tour de force that MRI does to be able to get cines, to get motion, and to get resolution.
Yeah. It's the most difficult organ to image with MR. And as you look at how MR technology kind of trickles down, usually neuro, like brain MR, drives it, because the brain is easy. It's just like a tub of water that just sits there. You can stick it in a coil and, it's not moving around. There's a little bit of CSF pulsation. And but like MSK, things like that. And then you've got body imaging. It's tough because there's, breathing and stuff, but the heart is a whole nother level. So a lot of times the innovation takes a while to get down to the cardiac level because, there's a lot going on there. And cardiac in a lot of ways drives innovation because you have to have really fast sequences to image the heart. You have to, be able to do these really slick reconstruction algorithms to be able to even make a useful image. And so, it's got its pluses and minuses, but it drives innovation, but it's also kind of, it's waiting for that stuff to trickle down. Because,
for sure.
Should we look at some pictures maybe just to show what kind of sequences? So David, if you want to move on to the next slide, we can show some examples.
And just real quick, I was going to throw in there just for the patients who are curious about how we compensate for motion for the heart moving and for the lungs moving. We do breath hold instructions for most of the sequences. So I'm a cardiac scanner myself, so I do hearts. And another thing that we do is we call it gating. So we'll set you up with some ECG leads and we just kind of compensate.
Yeah. And the way to think about it is if something's moving, but we're taking a picture. If you always take a picture when something is in the same spot, it doesn't look like it's moving. Right. But the faster it moves, the more chances your picture is going to be blurred. Right. So heart rate is kind of an important thing too. And, for sure. If something's moving up and down and you're going to take a picture every time it's down, but then it starts moving left and right too. Well, now you're going to have a blurry image. Right. So that's the gating takes into account all cardiac motion, but any other motion, be it respiratory, be it patient, it's not taken into account.
So is there a optimal rate range for cardiac scanning?
Well, I will say, speaking as somebody who is involved in operations and has to keep an eye on time on the scanner, cardiac CT, as slow the slower the better. So if we could stop people's heart and do a CT, it'd be great. We'd have trouble getting the contrast to go into the coronary arteries probably, and the patient probably wouldn't be too happy about that.
That's the advantage of MRI. Yeah. You don't require as slow. What you need is regular heart rate because you're gating. Yeah. So our biggest enemy is when a patient has a lot of arrhythmia, or when our gating capabilities are hampered by the RF signal. So we record an EKG, but as you know, Robert and Reggie, you both have seen, sometimes we start out, we put the patient in the scanner, we've got a great EKG signal, and then we turn on the RF signal, and then everything sort of disappears, and then the gating just disappears, and it becomes a headache. So we need regular rhythm. It doesn't have to be as slow as CT, but normal. And then the thing is, as you go faster, well then, you've got to compromise somewhere. So if your heart rate is faster, then you get less phases. So that's
I would say 60 to 80 is probably the sweet spot, and when you get up north of 100, things start to break down.
And at some facility,
the scan goes faster.
Oh, it's a shorter breath hold.
Yeah, it's a shorter breath hold. If your heart rate's 80, like I love 80 over 60 because the scan gets done 10 minutes sooner.
Right, you're like moving.
Having said that, MR is very used in kids, and children have faster heart rates, so that it can be used. It's simply the important thing is really to have a slow heart rate.
Right.
So, but for us, 60 to 80 is just perfect.
Yeah.
So we can pack it in, get 30.
Will you consider possibly medicinally providing some sort of, providing the patient with some sort of medicine that's going to help?
There's always a risk benefit, to anything. And anytime you give medication, you're piling something on the risk side.
Right.
So it really depends. So the main thing that, like Francois was saying, is you need a regular heart rate.
Yep.
So if you have somebody who has AFib and they're not rate controlled, then absolutely, give them beta blockers, try to slow them down, trying to get a little more late. You're basically treating their arrhythmia is what it amounts to. But when it comes to actual, for cardiac CT, we routinely give medication to slow the heart down. I don't think we ever really do that for cardiac MR.
Tough.
It's very, very.
We need a certain amount of regularity, and I guess you can do arrhythmia compensation, which is you'll basically create like a corridor where you're going to accept a certain time interval, and then those who are much slower or those who are faster you reject. But you end up losing data, obviously, and it takes a little longer for your scan. So longer breath holds or longer scan times.
Right.
So consistency is also key with breath holds as well, because I explain to patients, when you take in a deep breath, your anatomy moves down quite a bit. On a shallow breath, not as far. So we want it to move to the exact same spot every time. And so we want patients to consistently take in the same amount of volume on every breath hold. And actually, as far as inhalation, exhalation, which one is better? A lot of times exhalation is better for that reason.
It's more reproducible.
Right.
But it tires the patient. We don't realize, especially if you're a sick person, we're all healthy today, all tested COVID negative.
Right.
And for now.
Yeah.
But if you are an elderly person who's mildly short of breath, you're lying in a tube, with antennas over you and, covers and stuff like that, you can appreciate that people get tired breathing in, breathing out. Doing that over and over
It's a
again.
lot of breath holds for cardiac studies too.
So 60, 70 breath holds.
Ideally, if we can make scan times as short as possible, we try. But these scans tend to be.
And we were doing some protocol development stuff about a week or two ago, and I was the patient on the table doing expirations. And I'm a guy in my 30s who jogs, had difficulty with it. So,
was there a favorite vendor, someone that's doing a pretty good job with that, like kind of helping out the overall?
When it comes to that, I think they're all kind of around the same. That's always when it comes to you talking about getting a quick acquisition. We can get into the technical stuff later, but really, what speeds up imaging is having a multi-channel coil so that you can do parallel imaging.
Yes.
And then also this new thing, compressed sensing, which compressed sensing itself isn't new, but basically the software hasn't been powerful enough to use.
Right.
So as computer processors get more powerful, scanners now can start to do this compressed sensing. And you can definitely tell when you're using it. It's not as good. It looks different, but you're scanning the entire heart in 1 or 2 breath holds instead of 12, So
there's certain patients that are going to need
like, is
that.
it good enough?
Right.
You know,
exactly.
that's, but we can talk about that when we get into the intervention.
Well, that's
later,
actually,
so.
I appreciate that about you, because I've had to call you about certain patients and we kind of tailored it to that specific patient based on their needs. So, but speaking of needs, I'm curious about like, what is the common indications for an MRI cardiac? Now you mentioned congenital is kind of your experience, but I imagine it goes beyond that.
Yeah, I mean, congenital is a rare indication. Congenital disease is about 1 to 2% of the population, so that's quite rare. I mean, for the symptoms that I mentioned earlier, I mean, for us, the diagnosis of cardiomyopathy, myocarditis, so viral infection of the heart, to look for inflammation,
we
to
see
look
that
for
fluid
scar.
real good on MRI. Yeah.
It's used a lot in post-MI cases, because with the addition of gadolinium imaging, in addition to tissue characterization, looking for edema, area at risk, we can calculate EF, but also we can image scar size.
Right.
And the behavior pattern of gadolinium within, or the topography of where a gadolinium accumulates as a breakdown of the barrier between blood and myocardium occurs. As you remember, gadolinium is an extracellular agent that normally does not enter cells.
Right.
But in the case where cells have been damaged, or if you have an expanded interstitial space, then gadolinium may enter. So that's how we image, and each disease has kind of its own signature. Like heart attacks tend to be like in the inside of the heart. We call this subendocardium, or transmural as the heart attack progresses. Things like myocarditis tend to be on the outside of the heart, and that's a kind of a bit mystery for us why that occurs. So
when
the
you say
accumulation
outside of the heart, that's where the contrast
epicardium
enhances.
Yes,
Okay.
so along the pericardium. So there's often, when people have myocarditis, which is an inflammation of the heart muscle, they sometimes can have pericarditis, which is an inflammation of the wrapping around the heart, which is called the pericardium. So these things often travel together.
You have a nice image in here showing some of the physiology of delayed enhancement. Let's pull that up.
This is an example of...
Keep going. It shows some cells. I just kind of, while we're talking about
if we go back to the first one, the first double image we had, David. So that was just to show you the different sequences we have. So if we go one back of that, these are our static images. So there's no gadolinium, but it's just to show you what the versatility of MRI, showing same patient, same slice, different machine adjustments. The one on the left is a T1 weighted fast spin echo, black blood imaging.
Nice.
And the one on the right is a fast spin echo, but T2 weighted imaging with fat suppression. And you can see that we see different things.
Yeah.
And that's some of the tricks we have in our bag to kind of characterize tissue. Black blood imaging, because it is a slow technique, will excite all the structures within a slice, but blood travels, so it leaves the slice, and thus it is replaced by unexcited blood, so that when you turn off the excitation and you recoup the energy through your RF antenna, you get no signal from the blood. I'm simplifying it a lot, and then muscle, myocardium has sort of an intermediate density, and fat in basic T1 imaging is very bright because it relaxes very quickly, gives us a very bright signal. Now we can do inversion. So the one on the left is a double inversion recovery. The one on the right is a triple inversion recovery with a long TR. And then you can see, and the way you can tell this is T2 weighted imaging, CSF is water, and you can see here I've pointed with a white arrow. You look at the image on the left, the CSF looks dark in a T1 imaging, and yet it is static. It doesn't move like blood. So you can and then you can see that on the right, the T2 weighted image, then the CSF appears as bright. And also, if you look at there's fluid around the heart and around the lungs, so you have large pleural effusions bilaterally, and pericardial effusions, and inflammation within this matter. So this is all static, no gadolinium, but it helps us understand the anatomy, but also the physiology, even if the heart's not moving. Now, these are this kind of the workhorse, but the new workhorse is on the next slide. Clint, did you want to add anything?
No, that's fantastic.
These are really, this is what has become the workhorse of our cardiac exam, because the heart moves, as we said earlier.
Right.
So on the image on the left is a cine basically, which is a white blood imaging, SSFP, steady state of free precession, where your repetition time is about 200 times faster than a spin echo. So blood doesn't have time to escape the slice. It gets caught and returns the signal. Plus, we give it a little help with kind of a rewinding gradient, which is a bit of the principle behind SSFP. Yeah. And you can appreciate here, this is an example of a patient with pericarditis. You can see here, if I move my arrow, I don't know if I can make it into there, or just keep. Oh, yeah. So this is the heart. This is the wrapping around the heart, the pericardium. You can see that there's thickening here. And you see the heart muscle, like this is the right ventricle, the left ventricle, left atrium, right atrium. You see the pulmonary veins that bring back the blood from the lungs to the left side. And then you see the septum, which is that wall between the two ventricles is kind of wiggly a little bit. So this is an example of an abnormal septal motion that we see. Now, this is an image that's done during breath hold. That's why the image is so crisp and so nice. So the patient's not breathing. But then we can also, a derivative of that is to do real-time imaging, where we say to the patient, go ahead, breathe. So it exemplifies the limitations and the trade-offs you have in cine imaging. You see that we've traded off spatial precision for temporal resolution. Right. So we acquire more images. They are a little blurrier. But then what we can see here is that when the patient breathes in, and how do we tell the patient's breathing in? Well, the heart goes down, the lungs inflate with air. So as he's going down, so you see flattening of the septum. And then, so this is a clue that we have that the patient has what we call constrictive pericarditis. So it's one of those pericarditis that's squeezing the heart and making it difficult for the patient to breathe. Now, this patient actually had severe renal failure. So we did not inject gadolinium for safety reasons, but yet we were able to do a very nice exam in this dialysis patient with chronic constrictive pericarditis. So just to show that gadolinium is useful, but we can get a lot of information even without the injection of gadolinium.
You know, since you got that free breathing cine up, I did have a question for you. I've worked with you, and you've told me to make sure to include a free breathing cine if a patient has history of pleural effusion. Okay. What's the reason for that?
Often, when you have pleural effusion, you may have inflammation of the pleura. Pleuritis, we call this, and you can sometimes have what we call pleuropericarditis. So it's possible for a patient to have inflammation of both the pleura and the pericardium. And the other thing is, if you notice on this patient, perhaps we don't see it as well on this patient, but a patient with constrictive pericarditis like that may develop a kind of heart failure. The function is good, but these patients often have pleural effusions as a result of their disease. So when I see pleural effusion and the function seems to be good, our mind goes, and that's why
it's very negative.
I'm happy that you brought this up, Robert, because I think it adds to the need to flexibility and to sometimes make changes on the fly when you see something, because you sometimes discover things as you're imaging. So that's why it's important for you guys to communicate with Clint and I to tell us, hey, well, I've got some images. What do you think? Are we proceeding as the plan? Because we protocol cases, but sometimes surprises happen. And this
is also a nice illustration. We were talking about the importance of breath holding earlier, but you can do some imaging on a patient that can't hold their breath. It's not great. It's not as good, but you can get something at least, from patients, that short axis real-time imaging. And as the technical things like compressed sensing kind of come along and get better, we're going to be able to do more and more free breathing exams on patients.
Nice. So eventually you won't even have to hold your breath anymore for any MRI,
it could be.
right?
You just lay in there, but it's just a great example of, with MRI, there's almost always some sort of trade-off. So nothing is free. So, if we want to get a better temporal resolution and move away from a segmented case-based filling algorithm and get real-time imaging, we can do that, but we're going to pay a price. The image isn't going to look as great. We're giving up some spatial resolution.
These images were acquired with a 3T magnet, And again, it shows you. I mean, it's a you were wondering perhaps the differences between 1.5 and 3T. Well, I mean, for us in cardiac, I mean, 1.5 is what I've used more.
And we're talking about field strengths here.
Field strengths,
yeah.
So, but this exemplifies some of the strengths of. I compared kind of like riding a bronco to riding a nice service horse. The 3T is much more challenging for the technologist because you've got get your off resonance frequency, reduce your dark band artifacts and stuff. But once you get that, the smoothness, you look at that, the smoothness of the myocardium on the left is really quite nice. I've got other images later that were acquired on 1.5, and you'll see there are a lot. I mean, the signal to noise ratio is obviously
more of an issue.
Yeah, and that's what the reason why we. Almost like an arms race, like when it comes to MRI field strength, the original scanners were less than a Tesla.
Right.
And 1.5 Tesla came out, then 3 Tesla. Now they have some commercially available 7 Tesla scanners.
That's right.
And, by doubling your magnetic field, you automatically double your signal to noise across the board.
Right.
But everything else doubles too. So your artifact gets worse.
Yeah.
You really have to tweak things. Now for something that doesn't move a lot, like the brain, we all do almost all our neuroimaging at 3T because it's easy, know, and there's not that big trade-off. But for imaging the body, abdominal imaging, cardiac imaging, thoracic imaging, things that move, things where you've got a lot of these interfaces between areas that have protons and areas that don't, like the lungs. You get into a lot of artifacts and you have to be able to kind of mitigate that. And it takes a sharp tech to be able to kind of make the changes that need to be made to improve your image quality there. But yeah.
Imaging Diversified offers monthly support subscriptions with daily phone support. This comes with optional yearly training, a dedicated app specialist, and quarterly image review for your site. Visit our website to sign up today.
I see in the future, as we move forward, a return to lower field strengths and using technology,
to boost.
Yeah, exactly. So rather, like we can go to maybe 0.8 T and make it look like it was done on a 1.5 T because of the technical, the software sided things and the reconstruction side.
Because the safety factor, drastically
the artifact goes away, the MR.
Yeah,
so we can delve into that later.
Let's dive into it now. I'm curious if you just had if hypothetically speaking, you're the director, you're about to purchase just one machine for your department. For cardiacs, would it be a 1.5 or a 3?
It would be a 1.5.
Okay, and that's just because of
a 1.5. Yeah.
Is that because of restrictions with MRI safety and with
that's
the 3T?
That's a big part of it. I mean, the bottom line is there's good enough.
Just image quality. Which would you pick?
Just based off of image
quality alone.
Well, it depends. If you give me a perfect patient that doesn't have any metal inside them and can hold their breath forever, sure, do 3T.
Right.
But how many of those do we get? So I mean, taking practical considerations, I would rather get 95% good enough imaging and 5% on a 1.5 T than like 80% good enough imaging and 20% we have to bring the patient back,
right?
Because of some artifact or something. So
that's one thing, metal artifact, that clinicians have trouble understanding because we put so much emphasis on patient safety. So we say, pacemakers and all this. So a lot of the biological implants are now MR compatible. Right. So they are. They can be used. They will not cause injury or harm to the patients.
Right.
However, the problem with these is that they create a lot of artifacts. So we get patients sometimes sent to us to look at people with prosthetic valves, for example.
Yeah.
Or pacemakers. And I guess we can see, but even little coils or annuloplasty rings, these are all biological implants that create a fair amount of artifact and really are quite a bit of a hindrance to do quantitative measurements. You want to get a precise ejection fraction, look at the flows. Some of these implants are actually a big problem, which is not as much of a problem with CT. CT has less of a problem with artificial valves, and with the improvements, I guess, that that you guys have seen. I mean, I've seen some wonderful images of prostatic valves with CT, where you can see the valve discs, and it's actually this is stuff we can't do with CMR. So for the clinician, it's important. Clinicians don't understand always this thing. So
that struggle.
We try to bring this to get the right test for the right patient.
Yeah, and implants aren't getting less common; they're getting more common.
Oh yeah, for sure.
And just because it's MR compatible doesn't mean it doesn't throw off a lot of artifact. There was those implantable loop recorders, actually, they throw out a fair amount. They're very small, but they throw out a pretty good amount of artifact. And the thing to remember too is, with MR, everything is based off of us knowing what the magnetic field is.
Right.
And the problem with metal or any other kind of foreign body is it disrupts that magnetic field. And so it results in artifact in and of itself. But it also degrades your magnetic field. It makes it more heterogeneous. Yeah. So just overall image quality takes a hit too a lot of times.
One of the things that are metal but do not cause major problems are coronary stents. People who have like angioplasty and stents. So that's not as much of an issue. So
nice.
Those are they're kind of more discreet, and we can do the exam without that. They will cause a blowout region. You'll see a black or dark area. We can still navigate with that. They're not a major problem.
That's pretty cool. Well, one thing I did want to talk about, I think we kind of touched up on it, was the necessity and the role that contrast plays. So it sounds like it's not always necessary. But
it really depends on what you're looking for. So if you had to MR can do a few things that other things basically can't do or can't do very well. And one of those things is demonstrating myocardial damage, fibrosis, amyloid deposition, old infarct, new infarct, whatever. You need contrast really to do that well. And that is the main, I think when we give up contrast, that is the main thing we're giving up. Because even MRA, we're getting better at doing MR angiography without contrast. We haven't really, that's still in the process of trickling down. But when it comes to the delayed, although we'll see with the parametric mapping, a lot of times with the T1s, you can kind of predict, pre-con where an infarct is going to be based off of, the T1 and T2. Yeah.
But I don't have the confidence, though, that we have when I think they're complementary. I mean, late gadolinium enhancement is a macroscopic phenomenon that you see, whereas the maps give you sort of that microscopic, that sort of diffuse fibrosis that you may not be able to see at the naked eye. So the advantage, I guess, of gadolinium for scar imaging is that when it's big, it's really helpful. You really see it. But
and it drives clinical decisions too when we're talking about viability. If you have an infarct, is it worth revascularizing this territory? Is there any living myocardium? If it's enhancing, it's dead.
So you're not going to get any of that from CT.
You can't get that from CT, and you can't really get it without contrast. You can kind of make some assumptions, and not that it's the have all end all be all, but definitely the viability imaging with delayed enhancement. And then other places where it has kind of a prognostic capacity would be like hypertrophic cardiomyopathy. The people that have more myocardial fibrosis, delayed enhancement, tend to have more issues with fatal arrhythmias. So if you have 10 to 20% of your myocardial mass or more demonstrates enhancement, they get an AICD, whereas
so when you find enhancement, it's really a bad thing for the patient, whatever the disease is. Prognostically, you look at all the Kaplan-Meier curves in a given disease, be it coronary disease, myocarditis, hypertrophic cardiomyopathy, amyloid, everywhere. The more gadolinium you have, the more patients die. And fibrosis is something that interferes with the conduction of electricity within the heart. So it makes the electrical system less effective. Mistakes occur, and then that's how arrhythmias start when there's like short circuits that occur. Fibrosis is a terrain for this problem to occur, and that's how it correlates with sudden death.
So a healthy heart, you won't see any contrast enhancement.
Well, now here's an important distinction. The heart enhances.
Okay.
So do we have some delayeds in here, I think?
There might be.
I don't know. They might be further
These
down.
were, so this.
Here we go. Next one, I think, has the delayeds. Yeah, we're getting into here we go.
Nice.
So you can see those white areas there. But so basically, with delayed enhancement, that myocardium it's either not myocardium or it's dead myocardium. Oh. So, I mean, it's like Francois was saying, it's an issue, you know, you don't want to have delayed enhancement. Right. And lots of different things cause it. So having delayed enhancement, that's not specific. So specificity is kind of like, all right, this is what this is because, you know, I don't know, sensitivity, specificity. Right. It's not whether or not you have the enhancement, it's the pattern of the enhancement that gives specificity. So in this case, if we're seeing delayed enhancement, it's subendocardial, it's in a vascular distribution like left circumflex. Those are all things telling you this person has a big infarct. And you look at it and say, all right, there are areas where it's transmural, more than half the wall is involved. Right. You can revascularize that region, and there's a high probability it's not going to make a difference. But there are other regions where more than half of the myocardium looks like it's still alive. So, you know, if you revascularize, that area might perk up, and the ejection fraction might come back up. So,
you know, when you're saying delayed enhancement, so you're saying like, so technically it should wash in and then wash out?
That's right. Yes. The whole point of this is the heart enhances. So what we do back to
the previous slide, we can show you an example. So before that, so this is if we play that cine on the right, this is an example of a stress perfusion. So this, I must say, however, this is not yet an approved FDA use for gadolinium. Gadolinium really was mainly engineered as a angiographic agent. Right. However, some very intelligent and very observant radiologists in the early 1990s, and cardiologists probably, found that not only would you be able to opacify the cardiac cavities and the great vessels to do great angiography, you also could see the hue of gadolinium, this sort of graying that you see. So this is an example of a short axis view where you have here the, I don't know if my arrow is going to work again. So this is the right ventricle and then the left ventricle. So we inject the gadolinium in an arm after administering a pharmacological stress agent. In this particular patient, we gave adenosine, but there's different drugs that can be given, regadenoson or dipyridamole. These are other medications that can be used for stress. Right. They're very safe. And what we see here is there's an area that under-enhances here in the anterior territory, whereas you see the perfusion, as Clint was saying earlier, occurs more normally in the inferior and the lateral. And it just turns out, so these were the images in this patient who then moved on to have late gadolinium images that showed no late gadolinium enhancement. So this patient had what looked like coronary disease without having an infarct. And this is the patient's coronary angiogram that confirms this really, really critical proximal left anterior descending stenosis. So the patient underwent coronary angioplasty and stenting, fortunately before sustaining
this
an
is
MI.
ischemic myocardium. It's not dead, which is why it doesn't show the delayed enhancement.
Right.
So this is also a great example too. Is I don't know, like if you're not used to looking at cardiac MRIs, you might say like, why isn't this guy's heart beating? Exactly. But it's moving up and down. And so, you know, this is an ECG gated study where basically we're looking maybe 70 times at the same slice, but we're only looking at the heart at a specific point in the cardiac cycle. We're not watching the heart beat. We're only looking at, you know, usually late diastole.
Right.
And so that ECG gating takes into account that heart beating, and we're only looking at one specific point. So that's why the heart doesn't look like it's moving. But we're looking at that point over and over again over time. So we're watching the contrast. You can see it come into the right ventricle, going to go out to the lungs, come back, you know, into the left ventricle and out through the coronaries, and then, you know, perfuse the myocardium. And the reason it's bouncing up and down is because the patient's breathing.
Right.
And the ECG gating doesn't take into account respiratory motion.
Right.
So it's just a good example of how important the gating is here.
Sure.
And, you know, the thing that you'll see here is the myocardium enhances. And when we talk about delayed imaging, really what we're doing with delayed imaging, we don't mention it, but this is an inversion recovery sequence where one of the things that's really important to get good delayed imaging is we want to take normal heart and make it black.
Right.
And so if there's any abnormal heart, it stands out. It's easier to see gray on a black background than it is to see white on a gray background.
Right.
And so that, I don't want to say the heart doesn't enhance. It does enhance. It's just we are trying to null out. We're specifically targeting normal myocardium and say, let's make the normal myocardium black.
Right.
Because there's contrast in the myocardium. It's alive. So, it's not in the myocardium proper. It's in the capillary beds inside the myocardium, of course.
For sure.
In fact, the heart enhances, but then the gadolinium escapes and gets eliminated by the kidneys. It's the fact that it remains stuck and can't escape that determines that. So
the pathology.
Is that also why TI is so important for the contrast of the adjacent tissues, I guess?
Yeah, and one of the reasons why, there's one of the things about amyloid is, with amyloid deposition, you've got so much of these amyloid proteins around the body, and they kind of sponge up the contrast, and it pulls the contrast out of the blood pool rather quickly. And so a lot of times we'll have a lot of trouble setting our inversion time. First of all, because there's really not much contrast left. It's almost like, have you guys ever tried to do a TI scout on somebody where the IV infiltrated and you didn't notice? Oh, right?
Yep.
You're trying to set the TI and you're like, this looks weird. Like, this doesn't look right, right? Because there's no contrast.
Yeah. Like, should I chase it? Or?
The other part of that, too, is amyloidosis. It can be very focal, but it's usually a very diffuse process.
Right.
You need to have some normal myocardium somewhere to decide, like, this is what we're going to try to null. If you don't have any normal myocardium, if it's all chock full of amyloid, what do you null?
Right.
So
the key technical aspect with an inversion recovery sequence is that you should image every second beat. So every 2 beats, you need to let the signal recover.
That's a good point.
So you can't do it every heartbeat. So if you're analyzing or if you're doing it for the first time, that's one setting. Usually the vendors have it properly adjusted, but it's a little trick. It's important not to forget.
That's the other important point with cardiac. Cardiac imaging, we have all these time constraints. The heart's beating, the patient's breathing, they have to hold their breath. There's the thing you have to remember with some of these pulse sequences, especially the T2, is, it is like a horse basically, and you're beating it with, and sometimes you have to let the horse rest so it can run again. And if you just keep beating this horse and don't give it time to relax, if you don't give this signal time to recover so that you have something to work with your next pulse, you can get some erroneous exams. You might, your T2s might not look like there's any T2 signal because you didn't.
Do you ride horses often?
No, I look like I took my daughter on a horse ride a couple of years ago when I was too fat to ride a horse. I had to ride a mule. So,
that's awesome.
So no, I'm a mule man. So I guess once you get up beyond 2 bills, you're approaching mule country. So.
I'm not there yet.
Which is fine, So the mule and I got along. We're both really stubborn and kind of slow.
That's awesome.
I did want to kind of talk about pathologies and what are some of the most common ones. Now we keep talking about infarct in layman's terms as a heart attack, but we also talk about amyloid as well. What are, if you would, just kind of break down some of these most common things that we see as far as pathologies goes, and what would be like some of the common treatments for it?
Yeah.
In coronary disease, when we image patients who've sustained a heart attack, the importance is reestablishing flow in a blocked artery and then modifying risk factors so that patients don't do it again. So if you're smoking, stop smoking.
Right.
If you're a diabetic, take your diabetic pills. If you're hypertensive, take your blood pressure pills. And if you have coronary disease, well, you also need blood thinners that reduce the risk that a blockage may occur. Blockages can occur from cholesterol plaques, but also because of blood clots that form inside as a result of the cholesterol plaque being exposed, and then the blood in your bloodstream see this cholesterol and then just clumps on it and blocks the artery.
Yeah, but it's just, I just want to pile on that with a tangent because I was listening to a podcast about evolution and the evolution of blood. If you think about blood is fascinating because it has to be fluid and flow, to get from one place to another, but also it has to clot. If it didn't clot and you got a paper cut, you'd bleed to death.
Oh, yeah.
So, it's interesting. And so one of the things, if you think of the blood, the cells that line your blood vessels and heart are very specialized. If blood, blood is designed to kind of slide through that. And if blood sees something that's not that, it clots. It activates the clot. So what happens with these atherosclerotic plaques that rupture, you've got this normal endothelium, well, not normal, but an endothelium over it. But when that endothelium gets damaged, and if you tear a hole in it, basically, you've got this thrombogenic stuff underneath it. And so when people die from a heart attack, they don't die because they have this really tight coronary artery that they've had for 10 years, and now it's went from 99% to 100. They die because they have a plaque, and maybe they had a 30% lesion in their left main, and it went from 30 to 100% in a second. And that's when you die, because you're not compensating for that. I'm always amazed. We see these patients that have bypass grafts, very common. We image them, and 10 years out, a lot of those bypass grafts are gone. They're just not there anymore. They're occluded. The bypass graft is kind of like a bridge so the patient can build collaterals. Blood really doesn't want to go through the bypass graft. It will if it has to, but over time you build these collaterals around it, and eventually the bypass graft, if it's gone, that's good. It means your body didn't need it. So, most of the time. Right. Sometimes they block off and you don't want them to. But
so what's useful by doing an MRI in someone who's had a heart attack is you can see the extent of the heart attack. So the
where do you usually see it?
It depends which artery has been occluded. So if it's the LAD, the left anterior descending, it's going to be the anterior wall in the apex. If it's the right coronary, it's going to be the inferior wall, sometimes the right ventricle. And if it's the circumflex, Clint mentioned the circumflex earlier. We saw an example of a circumflex infarct. That's the side of the heart.
Oh, okay.
Now, it's a heart attack is a heart attack is a heart attack. The thing that you may get from MR can also be obtained by echo, the function and stuff. But what the MR brings to the table is the amount of scar you have. Prognostically, that can be useful. What also happens is that, for the reasons Clint mentioned, some people will develop heart attacks without having those cholesterol plaques, but they will develop the blood clots within their system. And we call this myocardial infarction with normal coronary arteries, MINOCA. So that's we're acronyms. Right? You're always acronyms. So MR is actually a very useful technique to look at these patients who've had what seems like a heart attack. They have an abnormal EKG. Their blood enzymes have gone up, and yet we don't have an explanation.
Right.
And some of the explanations may be inflammation of the heart from a virus, so myocarditis, what we were talking about earlier. You can have other types of so like a vasculitis, some of an inflammation of the blood vessels, some hypercoagulable states, meaning your blood clot system is too eager to form clots. So sometimes MR can be useful in those patients as well to see the extent.
Cool.
So finding how big the MI is and finding alternate causes when you don't have coronary disease.
Yeah. Right.
And then the prognostic information is that the more gadolinium enhancement you have and the lower your power of your heart, as determined by what we call the ejection fraction, normal about 55, 60%. So if it's very low, then these patients have to be watched really carefully. They should be on some specific medication. So you can tailor the treatment following a heart attack with the use of an echo or an MRI to give the patient the best treatment, including reestablishing coronary blood flow.
For sure.
So other diseases that we have things like valve problems. So ultrasound is really good, echocardiography to diagnose. But we do have in our bag of tricks in CMR, we have phase contrast, or PC cine. So we can measure blood flow, and we can actually calculate how badly a valve leaks. So, and we don't need to give
regurgitation.
How much regurgitation. So we can use that to see. Sometimes ultrasound is really good, but sometimes we're not always sure of the amount of leakage. So that brings...
So is that when you would order like velocity flows?
Velocity flow, yes. Phase
Okay.
contrasts, PC image or velocity flows.
Okay.
And then, so you can use that for that.
Yeah.
Congenital heart disease is one that I use a lot. And that was one of the reasons I started getting interested in that. And there we use 3D angiography, and we had an example, I think, maybe
it's coming up.
While you're pulling it up, Dr. Jokerst, when you see these velocity flows and you're looking for aliasine and whatnot, what else is it that you're looking for? What is it that you use what tools do you use to evaluate that?
So when we're talking about, phase contrast imaging in general, if you keep going backwards, but so basically that is the color Doppler / pulse Doppler equivalent from echo. So you've got phase contrast imaging. Basically what we're doing here is, I don't want to get too deep into the physics, but you can look at protons and see how many they are moving, in what direction they're moving, and how fast they're moving. And so from that information, you can get a variety of things. And so you had mentioned aliasing. And so analogous to a color Doppler on echo, basically when we're imaging using this technique, we have to decide what velocities we want to look at going in. And if our velocity scale isn't set properly, if it's not broad enough, what happens is if you have some protons that are moving faster than your velocity scale, the scanner doesn't know where to put that signal because it ran out of space, right? So, if you're set at 200 centimeters per second as your top and it's going 250, there's no 250. It doesn't know what to do. So it wraps it around and sticks it at the bottom. Now that is an immensely oversimplified explanation. I mean, to get into phase aliasing, we could talk about, the true nature of reality and the quantum electrodynamics and, field theory and really dig into that. If we really, we would.
To simplify, it's white blood imaging. Basically, and it does exactly the opposite of fast spin echo, where the blood is black. In velocity mapping, what we do is we basically add a supplemental equal but opposite direction gradient that sort of nullify the signal of stationary tissue and highlight what moves in and out of the plane. So with blood imaging, we try to suppress the blood signal. With velocity mapping, we suppress everything else but what travels. And the way the sequence is engineered is that the amount of phase change is proportional to the velocity of flow, basically. So we can take an educated guess. And as Clint was saying, often the patient's going to have an echo or something where we can measure blood velocity. So we can ahead of time sort of say, hey, the echo got 250 on the velocity. So let's maybe let's do 260 or 270 so we can we make sure we don't alias and so we can take like an educated guess.
Is that one of the recommendations? Like, do people usually have echoes right before they have an MRI? Or
it's pretty common. I would say at least 80%.
Yeah, typically echo is more of a first line test because it's cheaper, it's faster to do, it's real time, and it's portable. So whether you're in the ICU, the emerge, or you're outpatient, the machine can be wheeled in. The MR is a little more
not quite as
Fort Knox. It's like a little more of a secure area. So we got to be really careful with our
especially where we work.
I'm going to use this as an opportunity to talk about 4D flow. And so when we're talking about phase contrast imaging, what we're doing here is when we set up our flow gradients, our phase gradients rather, to look at flow, basically what the tradition has been we can look in one direction. Head, foot, left, right, up, down, whatever we want to set that direction to. But we can look in one direction. And it would be ideal to look in three directions because we have three spatial dimensions, right? So you could go head, foot, left, right, front, back. And then by looking at in any particular spot in your scan volume, any voxel, how that changes kind of up, down, left, right, front, back, you can actually take those three coordinate systems into account and get an actual true direction and velocity. And so the problem with looking in one direction, say we're looking head, foot, is the equation that we use to figure all this out, I think has a cosine function in it. And so if you're not exactly perpendicular 90 degrees, for every little bit you're off, you become less accurate. You lose a peak velocity.
For sure.
And another thing I will mention too is a weakness of MR compared to echo is when we're using this one-dimensional technique like this, we're we're like setting up an imaging plane and scanning it, but it's not a real time. we scan it and then we look at the image. With echo, you've got a probe and you're looking around and you can kind of like turn and twist and go like, oh, here's the worst spot, the vena contracta, so-called. Right. And so you can kind of dial in right away on that. With MR, it's kind of like you're chasing your tail. Like, all right, we need to go up a little bit. And then the patient takes a different size breath and now you're too high or something, you know? And so one of the advantages of the ability to look in all three directions and do that is now what we can do is we have this volume of 4D data. The fourth dimension is time. We can load that into a post-processing program and retrospectively change our imaging planes to wherever we want. Because typically MR will underestimate velocities and flows relative to echo because we can't get exactly on the tightest spot or exactly 90 degrees like echo can.
Now, is that something you do on Circle of 42 or
yes.
like, okay.
Yes. Yeah. But all the processing is retrospective with this. We can't you know what I mean? Like you're going to give me something, I'm going to throw it in a Circle 42 and process it. Now, the 4D flow, you can imagine every single, a voxel is a pixel in 3D. So on a 2D display, we can show, height, front, back, left, right,
Yeah.
A voxel is that plus slice thickness. And so with MR, we could really get into space time now. We're talking about, is the universe pixelated, right? So, but there's
Let's say that for another podcast.
Yeah, there's a smallest unit, kind of this length, width, height, then that's the voxel, and we can't get any more precise than that when we're assigning signal. And so when Francois was talking about spatial resolution earlier, that's the rate limiting step. So if I can tell how much signal's coming out of a voxel, but I can't tell anything beyond like it's coming from this part of the voxel or that part of the voxel. So that's your rate limiting step. But so for this 4D flow technique, we have all this information for all these voxels. You can imagine you have this phase information of the cardiac cycle in all three dimensions, and we're going to kind of like add them together and try to figure out what's really going on. The post-processing is immensely time-consuming. It requires very powerful computers, very powerful programs. And so the 4D flow is just now kind of coming on the scene. It's going to be great because it's very much like CT in that you get a data set that you can slice and dice retrospectively. And so we can dial in on the tightest spot and make sure we're 90 degrees so there's no gap anymore.
Yeah.
But the problem is these sequences take a long time. And this is where compressed sensing comes back in. Compressed sensing is it's a mathematical technique. A Fourier transform is a mathematical technique. It's just a different mathematical technique basically to take, I don't want to get into sparsity and all that kind of stuff, but basically it's math magic. And I like that. So by using this math magic, we can take what used to be unattainable, a sequence that would maybe take 40 minutes just to run one sequence, and do it in 5 to 10 minutes, which is a little more useful. They're usually free breathing, gated, cardiac gated and respiratory gated. But that will be a game changer, I think, for cardiac MR, the ability to do this 4D flow. Because now think about it. Say we want to do a flow quant on a congenital heart case, we're going to flow quant the main PA, flow quant the aorta, flow quant the left and right PA at a minimum. If any of those are out of plane or if there's aliasing, we have to repeat it. With 4D flow, it's one thing, and you can do flow anywhere you want.
Oh, nice.
Every vessel,
That is a game
so
changer.
It makes it a lot easier because especially if you've got patients with complex baffles or rerouted anatomy, you can kind of add up the blood coming from all these different spots. Now, here's the problem. You only have one velocity scale, right? And so you kind of have to pick, if you get it wrong on a 4D flow and it took 12 minutes, now you got to do another 12 minute, right? So, but the bigger your velocity scale, the less accurate your measurements become. So if you want to measure the aorta, but you also want to measure pulmonary veins, which have very slow flow, you can't do it. Scale. You need a tight scale for the veins and an open scale for the arteries. And so they're working on figuring out ways to kind of do two at the same time.
What's the fourth dimension? Time.
Yeah.
Good. The thing that's important though also is that when we use the velocity mapping is we try to pick a spot that's relatively quiescent. We try to stay away from turbulent areas when we want to measure flow.
Yeah.
When you have,
So is that why you go just proximal to the valve?
Or like we go to the ST junction instead of at the sinuses of Valsalva, because the sinuses of Valsalva, there's lots of
Gotcha.
what we
You
call
want
eddies. So this introduces flow disturbances. I mean, the flow dynamics are quite complex. So you want to pick an area that's relatively calm. So maybe the sinotubular junction or ascending aorta. And the same thing for the pulmonary artery. The thing that echo does better is that it has in its armamentarium something called continuous wave Doppler. And that is able to take the maximum velocity. So it can always overdo MR by obtaining higher velocities because it's able to obtain the maximum velocity along an axis. It does not have any precision in terms of location, however. So there's always a trade-off in science and in imaging.
For sure.
What we have here is we're better than ultrasound in my comparison, my experience, to measure flow. We're perhaps not as good to measure peak velocity because we're not necessarily at the area that's the narrowest. Where the velocity accelerates the most, and Clint called that the vena contracta. That's the technical term for that. So that's one thing. So certainly, I mean, it's a useful thing that we can use for flow quantitation. We can use it to look at shunts. We can like if there's a hole in the heart or between the two circulations. You can compare the flow in the pulmonary artery and the aorta, and understanding how the flow dynamics are, where the hole is, you can deduct how much shunting there is, and that can determine an indication for an operation, for example.
If you don't mind, just explain to an idiot like me what a hole in the heart is.
A hole in the heart is a common malformation, a congenital malformation. The heart develops in the fetus between let's say the 6th and the 12 weeks of gestation. It starts earlier. It starts, since day one, basically. But it becomes a heart, with time. The blood cells organize into tubes, and these tubes basically come together and fold on themselves and generate through kind of a miraculous process, valves and ventricles and atria, and during the embryogenesis, which is when you have an embryo that becomes a fetus, the tubes need to close. There needs to be a what we call septation, which is closure within those cardiac tubes to separate the circulation that goes to the lungs from that goes to the systemic circulation. And there are little mistakes. The commonest hole in the heart or septal defect is one between the ventricles.
So is it like a fistula, sort of?
You could say that. I mean, it's basically a hole that allows blood from the high pressure chamber, typically the left ventricle, to send blood to the right ventricle and pulmonary artery. So
how detriment is it to?
Well, it can, if it's very small, none. But if it's fairly large, what it can do is it can, with the amount of blood that travels through the lungs, it can overwhelm the lung circulation, damage the pulmonary arteries, and cause something called pulmonary hypertension, which is not a good thing. And then so those are for certain shots. Not all holes in the heart will cause pulmonary hypertension.
And again, I'm an idiot, but I'm curious. Are you able to is that something you could graft? Or and the tissue could regenerate?
It does sometimes, yes. Many, if not most, of the septal defects can close spontaneously. Not all of them. If you have a very large one, it will grow, but it's a bit of a race against time. When the baby is just born, you have this large hole, and as the baby grows, the hole tends to close down a little bit, but sometimes it just takes too much time. And if the doctors don't intervene and patch that hole, either through surgery or sometimes in older babies and adults and adolescents, we can use devices that can be implanted by catheter. These are also available. Nice. So you can close these defects before they cause pulmonary hypertension.
So you're able to diagnose it while it's
typically it presents with a heart murmur that becomes manifest in the weeks that follow birth. The more complex defects, the ones that have like septal defects, or missing arteries that cause mixture of blue and red blood, will be much more manifest, sometimes as early as birth. So those complex defects, which are fortunately very rare, can be diagnosed shortly after birth.
Thank you. I don't always have a cardiologist across the table for me.
Cyanotic is the term, like cyanotic heart disease.
Okay. And how common is it?
Blue.
Yeah, cyanosis is when you send deoxygenated blood out into the systemic circulation, and it means different things in kids versus adults.
Does that mean that you could be ischemic as a result?
It could be typically, but ischemic heart disease in children is pretty rare, and there are a few things that cause it, but it's not heart ischemia, it's body ischemia, basically. Blue toes, blue fingers, blue lips.
Yeah.
So congenital heart defects occur in about 1% of individual, and complex defects like those that cause cyanosis is about 1/10 of that.
Oh, wow.
So let's say 1%, it's 0.1%. So it's very rare, 0.1%. So 99.9% of those born do not have these complex cyanotic defects.
Wow.
And they used to be a death sentence, really, as recent as the 40s or 50s? When did they start doing open heart surgery?
Yeah.
I mean, there are things now like in secundum ASD that somebody can fix through your femoral vein in 15 minutes now.
Outpatient procedure.
Right.
Wow.
And whereas, in the 30s, it was a death sentence.
Wow.
So
is there any pharmaceutical thing that you could do to kind of help regenerate that tissue?
We don't have that yet, but once you have pulmonary hypertension, unfortunately, if your defect was not corrected, and you have pulmonary hypertension, then it's no longer time to correct it. You have to treat with medications, and there's some medications that can be given to people with pulmonary hypertension to reduce the vascular impedance, so the stress. And those individuals sometimes can go on to have heart-lung transplant, sometimes if they have pulmonary hypertension and a sick heart.
Sounds like you're talking about stem cell therapy, though.
Well, that's what I was thinking. Yeah,
it's on the horizon.
It's coming. I think there is research ongoing that. I don't use that.
Yeah.
Where you could regrow like a septum that is probably research that is ongoing right now. I don't think it's ready for clinical prime time yet, but I think
maybe 10 years. It's hard to say, right?
It's hard to say.
So many hurdles, right?
But it seems like it's going that direction. I mean, they're using stem cells to regenerate like labrums and stuff like that within joint spaces, and you're avoiding surgeries that way. But
ears on mouses.
I mean, if you could avoid a heart surgery,
right? Oh my gosh, or a heart transplant.
It depends on what you need to do. But the great thing about stem cells is you put them next to some cells, and they turn into those cells, but getting the stem cells where they need to go and keeping them there is
the logistics
of it
all.
So you can imagine in the heart, it's moving and beating, it's got all this blood flowing through. How are we going to make these cells that don't yet know they're supposed to be heart cells?
And I've never given this any thought, but in my mind, I'm thinking if you grafted it, right? And you created that link between, and then you gave that.
You think you take a chunk of stem cells and put them.
I'm probably making myself like an idiot.
But the thing is, how do you get them there without doing surgery?
Oh, for sure.
Yeah. And like you said earlier, it's a lot less invasive now. You're going through your femoral artery just down in your groin. So it's not like it's, they're cracking your chest anymore.
But they are. I mean, they're doing experiments in pigs and rabbits and all that kind of stuff where they are cracking their chest. And these patches when fused with stem cells, And
I did want to, since we are just talking about hearts and you mentioned pigs, at our facility soon we're told that we're going to be doing some research on cardiac scanning for pigs and stuff like that. And I'm curious about your impression of the similarities between the two anatomies. Because I tell you, when I was in x-ray school, I was given, the assignment of a class presentation on whatever it is that you wanted. Well, I chose to do hearts, and I brought in some pig hearts. As like a visual aid. And I brought up an example of how I think, again, I'm an idiot, but probably back in the 70s or so, there was an experiment where they actually did a transplant. It was successful for, I think, about 12 minutes or so.
Oh, like a heart into a human transplant?
Pig heart into a human,
I was actually involved in a research project at my last place where we actually skinned these on 3T Skyris. They were pigs.
Look that up real quick.
We would take a patch with stem cells on it, and basically they would give the pig an LED infarct and then put the patch on top of the infarct and see if the stem cells would like regrow the myocardium.
Sort of the same concept then.
Yeah, the same kind of concept. But when it comes to imaging pig anatomy versus human anatomy, I'll tell you, the first thing I noticed, pigs are buff. Compared to humans,
density,
their musculature is way more developed to the point where you get artifacts, dielectric effect from all the water, from all the muscle cells. So, it's you don't really appreciate how weak humans are. Even like weightlifters, they've got nothing on.
Right. So it's like imaging the rock every time.
Yeah, exactly. Pigs have a lot of muscle. So.
It's a good model to compare to the human in terms of the way the heart is made. I mean, if you compare to other animals, there's been attempts at other animals that
use
are common.
valves, right?
So I mean, dogs for one have. They're cute and they're nice and we like them.
Some are.
I like dogs.
Some are.
But one of the advantages that dogs have over humans is a much richer amount of collateral flow. Whereas pigs does not have that. The pig's actually a very, very delicate heart. I mean, I remember doing CMR in a pig model for infarction and a stress model. And whenever you occlude an artery in a pig, they arrest. They're really, because they have a very poor collateral flow, sort of like humans, but worse even. So they're very, very they're very, very delicate, and you have to be really careful if you do experiments on pigs. Rats or mice, well, the thing is that they're smaller and the heartbeats are like.
Up there.
A rat is maybe 200-300 beats per minute, and mouse 400 to 600 beats per minute. So it's like it's just like so it defies the capability. Yes, you can do high field imaging at 17 and a little bore, and do that. But I mean, it's just a different ball game there.
Right.
So in terms of that's why. I mean, it's
pigs are good.
It's just close.
Again, I found it interesting. I went to Food City and bought some pig hearts and brought it into the class.
You could just buy pig hearts out there like that?
Food City, you can.
The way also humans are made, if you look at our shape, we're sort of I guess horizontally.
We don't have it deep.
They're round.
Yeah.
So when you do imaging, I've done a fair amount of ultrasound imaging on rats and on mice, and the windows are not the same. The 4-chamber view that we can easily get in humans, because the heart is sort of splayed, is much more difficult to get in a rat or in a mouse, even if you have the proper probes. And then so things are a lot more cylindrical in rats, mice, and pigs compared to humans, which we're flatter basically.
Right.
Our thorax are flatter. I mean, if you're a big smoker, you can get barrel chested after many years of smoking, but we're typically fairly flat.
Right.
And our heart is, so we're I guess, easier to image in terms of ultrasound. And I guess MR doesn't care because it's 3D.
Cool. I'm curious because you mentioned chronic smokers were just long-term smokers, but what about people with alcoholism or something like that? Does that affect any heart disease?
Yes, it can actually. Alcohol is a bit of a depressor of cardiac function. So if you drink a lot, you can sometimes develop what's called a cardiomyopathy, where your heart muscle is weakened by the alcohol. The other thing is that this depressant effect sometimes can cause stuttering in the electrical activity. So typically, if you go, for your party out on Saturday night, we often see as cardiologists on Saturday morning in the emergency room a 30-year-old who comes in with what we call atrial fibrillation because of the effect of alcohol. So you've got to be really careful. Some people are very sensitive. It is probably genetically determined, your genetic propensity to arrhythmia and your genetic ability to metabolize alcohol, and it's sometimes the byproducts that can also play a role. So So
don't drink yourself into an arrhythmia.
Plus,
feel like
for the liver, it's hard.
Right.
I'm happy. I feel like we've covered a lot today. I appreciate you guys being here.
Yeah.
I am curious though, is there anything that you feel like maybe you would like to touch up on before we close out the episode?
Go ahead, Francois.
I don't know.
Anything you guys are excited about that's coming? I mean, other than stem cell, I know we
And
kind of touched that a
4D.
little bit. And
Yeah,
4D.
so I mean, I
it's
think
a good one.
4D flow definitely is going to change the way we do cardiac MRI. You know, we
Nice.
had a little experience with strain imaging, subsegmental strain. You know, that's another thing. I think that's
Strain.
up and coming. But I think in general, what we're going to see is it's computers basically that are changing it. It's Moore's law, you know. It's,
Right.
That is really,
Right.
you know, one of the things that people are always talking about in things like, you know, venues like this is artificial intelligence and machine learning,
Right.
and that is already starting to change some of the things we do.
Right.
But you know, you're going to see MRI, I think, continue to get safer, to get faster, to get better. The types of pulse sequences we can do are going to get better. And then the other thing that you're going to see that people don't really think about is the post-processing, right? I mean, that's going on in the background. But, you know, 4D flow case of complex congenital heart disease,
Right.
you know, it might, even with the best software available now, you know, it might take 2 hours to process it. Whereas, you know, in the future, who knows?
Who knows,
You know,
right?
it might
Yeah.
be
Automatic,
you know,
and it's done right when you send it over there, right?
yeah, it's going to take time because cardiac is hard enough.
Yeah.
But that subset of cardiac congenital heart disease. So, you know, we have some algorithms now that are pretty good at like automatically segmenting the left ventricle, but feed them, you know, a DTGA status plus baffle with the systemic, you know, ventricles, their morphologic right ventricle. It doesn't know what to
It
do.
just confuses them, right?
Yeah, I mean, it's
A word for the technologists. I mean, as we, you know, we've talked about in this segment. I mean,
Yeah.
it is a complex area of MRI.
Right.
We do have credentialing for physicians. You know, level 1, level 2, level 3, and I think, you know, if realistically, if you are a technologist and you want to get into cardiac MRI, it takes practice.
And you got to watch this podcast, by the way? No.
yeah, that's
This
right.
will help, but also you need to read up on the anatomy,
Right.
understand the physiology, basic stuff.
Right.
We know for us as physicians, to achieve a certain level, we need, you know, like a level 1 is 50 cases, a level 2, 150 cases, and a level 3, 300 cases in training. So I'm just saying that you have to be patient.
Right.
You have to read, and you have to have a good amount of support team around you.
For sure.
And it will not happen overnight. You need to do cases, and it takes time because these require, even if the vendors are offering great tools to help you with the planning, there's always stuff that happens.
Right.
You know, and so I think it's probably one of the most difficult areas of MRI.
Yeah.
And I think that I think we need more people to understand.
And I feel like
it.
I can relate to what you're talking about because I'm just a new cardiac scanner myself.
Level 1?
Oh, is that what you want to call it? I feel like I'm a 3, but haven't done 300 cases yet. But probably done about a 50, maybe. But
Nice.
You're right, though. There's a lot of
Every
I don't
heart's
know.
different, right?
a lot of different factors you're taking in when you're first coming in. It's a lot of unknown. So the anatomy itself is kind of new to you.
Mm-hmm.
You get kind of a foundation of cross-sectional anatomy, but usually heart anatomy isn't usually, you know.
It's different from person to person.
Yeah.
It has its own anatomical planes. You know, I guess MSK is kind of analogous, but with MSK, you know, there's only so much
Right.
a joint can be like. You know, what I mean,
Yeah,
a
it
joint
can
is a
vary,
joint.
right? Yeah.
Like, you know,
Exactly.
you still have like your 3 basic planes is just relative to the joint, but with cardiac, you know, you've got your like horizontal long axis. Vertical long axis,
Right.
3-chamber, LV outflow
sure.
tract, right ventricular outflow tract,
Right.
perpendicular view. I mean, it's, you know, it's just takes time.
And he mentioned a good support group behind you, and if you're lucky enough to have a Dr. Marcotte that you work with, that you can
Dr. Jokerst,
ask questions often, because he's always happy to answer
yeah.
them, and I find that a lot of you guys are happy to answer them.
We enjoy
Dr.
it.
Jokerst as well. I mean,
that's why we're
not every doctor is approachable, but obviously these two are. So, no, thank you.
So we're letting you guys
honestly.
borrow them through this podcast. That's right.
One tool that I found really useful from certainly from the cardiology standpoint, the European Society of Cardiology has a nice app that's called CMR Guide.
Oh, David, you could probably pull that up real quick.
Very well made that you can download, and basically it offers you a lot of information on the organization of an exam, the scan planes, some of the indications, and it provides very nice video content and examples of some of the sequences used. So if you're interested in that, I would definitely check it out. They also have a calculator that comes with it that can help you quantify ventricular mass.
Is this a free resource too?
I think it is, yes.
Wow.
They have
amazing.
resources in congenital heart disease. They have a physics handbook. So it really explains things really quite clearly. So the Europeans have been
on top of it,
pioneers in cardiac MRI. Physicians in the UK, in Germany in particular, have played major roles in the advancement of CMR.
Right.
And I want to tip my hat to their hard work.
Yeah, for sure.
Shout them out for
Big
sure.
shout out.
Awesome. So you mentioned earlier that you see safety being something that is more to a focus in the future, but you also mentioned earlier in the podcast that you see like Tesla strengths becoming reduced, the magnet itself,
and that's definitely
and that's kind of related to like safety.
Yeah. So as magnetic field strength increases, of course, the danger increases.
Yeah.
And one of the other things too that a lot of people don't think about is, when you have a magnetic field, we've got this magnetic field inside the bore that's 3 Tesla.
Right.
There's a magnetic field outside the bore that's got to be, balance that out. Right.
Exactly.
And so one of the things that engineers have been doing well is they call that a fringe field.
Mm-hmm.
They're getting better at shaping that and getting it smaller. But there's a downside to that, because as you approach a 3 Tesla magnet with something ferromagnetic, in the olden times, you would feel a tug, and maybe the tug would get stronger within a foot.
Oh, right.
Now with those really tight fringe fields, because they're trying to, get it all in out of, zone 3 as much as possible.
Right.
You might go from a tug to getting ripped out of your hands in that foot.
Yeah.
And in the future, it's not inconceivable as we move towards weaker, lower field strength and used, computers and technology to kind of compensate for that. One of the big thrusts in MR is getting away from using hundreds and hundreds of liters of liquid helium. So I know there are a few scanners, or at least one scanner coming out of the market.
Yeah,
I think it uses 6 liters of liquid helium.
It's pretty impressive.
Such that, one of the things is when you're putting an MRI scanner somewhere, it weighs a lot is one thing. But the other thing is if you ever have to quench it. So I don't want to get into like superconductors and how cool they are and all this kind of stuff. But the bottom line is, if you want to turn an MRI magnet off, that's a good point here is it's always on. The MRI is always on.
Always on.
The magnetic field's always on. The only way to turn it off quickly is to heat it up. The only way to heat it up is to evaporate out all the helium.
Yeah.
And so you need a vent capable of taking 2,700 liters of liquid helium, which is about to turn into tens of thousands of liters of gas. And so it limits where you can put an MR. Right. Now, if you only have 6 liters, that becomes, however many hundreds of liters of gas. You can actually quench the magnet inside. You can have like a chamber, and like just divert the gas somewhere else and turn the magnet off. Yeah. And so it saves helium too. And then you can bring it back. So now you put the magnet wherever. You don't have to worry about the vent. Right. So that's a big deal. I could foresee now this is just me, but in the far distant future, you could potentially turn a magnet on and off that way, right? Oh. The problem is you have to shim, and all that. And every time you quench it, it's hard on the gradients. But, engineers have dealt with much more difficult problems in the past. We can detect gravitational waves. We should be able to do that. But in the future, I could foresee one of the big things for MR safety would be, basically being able to turn the magnetic field off and on. And maybe if you can turn it on, you can turn it on slowly. And then a patient can be like, I forgot I have an eyelash curler in my pocket. I feel it tugging. So, I think that there are a lot of exciting things on the horizon. And, I don't want to get into my philosophy on life, but, if you could look back at kind of what things develop and what don't, the course of history and kind of where we go, it's really capricious. And a lot of it is based off of, just like random chance or luck. And so honestly, I have no idea what's going to stick and what's going to, go by the wayside.
I think you're onto something for sure.
Yeah.
Dr. Marcotte?
I just had another comment in terms of educational materials. The Society for Cardiovascular Magnetic Resonance, SCMR, is also a very important site based here in the U.S.
Thank you.
But for cardiologists, radiologists, technologists worldwide, SCMR, and I think that's a really great website. A lot of educational material. Also produces the Journal of Cardiac MRI.
Do they have a forum there?
JCMR. And
nice.
So that's a great. They've got great modules, teaching modules for cases, and it's a great forum for technologists. It's only people who are interested in MRI.
Nice. We like that.
So it highlights the importance of collaboration between radiology and cardiology, and the very special and important place of technologists within the field of cardiac MRI. So that's another great tool, and I wanted to make sure I
give them a
shout out.
Plug for them. I think they're doing great work, and I think it's a
great
organization.
This will all definitely be in the show notes below, so don't try to have to write everything down. We'll definitely leave a link for you at the bottom. So
Dr. Jokerst, Dr. Marcotte said, as far as techs out there, we'd really like for you to kind of focus your attention on learning the cross-sectional anatomy, learning the physiology of the heart itself. What would your message be to those MR techs that are just learning how to scan it, cardiacs?
Well, I of course, that's the most important, is being able to appreciate the anatomy, because you need to be able to do that to even get started. In the physiology. But kind of the next level is going to be understanding the physics to some extent.
Right.
And, physics is a wormhole or rabbit hole that will go, there's no limit to how deep it goes, right? We really don't what is time? What is space?
Right.
What makes a thing, right?
Let's not get too
these
deep.
seem like the base, we don't know the answers to that, right?
Yeah,
and so
it's a tough question.
Physics is, that's what I like about physics. It's very, we fall into this trap of thinking that, this is why things are T2 and this is why they're T1. Well, we have an explanation that fits why things are the way they are. But, Newton had a great explanation of gravity, and it sent a man to the moon.
Right.
But it couldn't explain a small variation in the orbit of Mercury. And so now we have general relativity, and general relativity is great. But we are creating theories and models that explain things and predict things, but that doesn't mean that is why things are what they are. And so getting back to the physics, being able to understand basic artifacts and how to troubleshoot them, I think is very critical with MR, because there are some things I've seen it before. There are techs that'll say, hey, we can't do this. This isn't going to be great, but then you change around a little bit and it's okay. We can get by, knowing when to use pulse gating versus, if ECG gating isn't working, knowing, when to try to revert back to spoiled gradient echo instead of steady state free precession, knowing, why spin echo has less artifact and which sequences are spin echo versus, gradient recalled echo. So
for sure.
I would, I'm always talking about the physics side of things. And I would say you don't have to be a physicist, but it's important to know the common artifacts and how to troubleshoot them.
For sure.
That would be my plug.
Yeah.
And if you really want to get into the why of MR physics, there's a website called MRIquestions.com.
Oh yeah, MRI questions.
But that you can really get into the weeds on that website. But
Nice.
And we referenced that website before. It's a website that we visited before for sure.
And I'll put that at the bottom of the show notes as well.
That's the message that you would say for MR techs that are learning how to scan. What would you say, cardiac studies? What would your message be for your peers, those rads that are looking to be cardiothoracic rads?
I mean, the same thing.
Understand physics,
you got to know the physics. It's, we have a luxury where we are to have Francois and, people like me that can get on the, you can tell me on the phone what's going on and we can troubleshoot it, in person. But lots of places may or may not have that kind of ability in being able to kind of troubleshoot that. I would say for cardiologists and radiologists out there, who are interested in cardiac imaging, again, just having a good understanding of the basic physics, because by understanding the physics, you can predict what's going to make things better, what's going to make things worse.
Right.
Somebody can't hold their breath. You're not going to run any segmented sequences.
Right.
They're going to be garbage.
Right.
So you automatically, all right, I'm
free breathing.
Cut that.
Yeah.
So.
Well, as a backup, what we'll do is we'll just put these guys' phone numbers in the show notes as well.
There you go. Yeah, just page me anytime. You guys say, it's 2 a.m.
He's half kidding, but he's half serious. Dr. Marcotte, for your peers out there, what advice would you give as far as MR specific advice would you give to those other cardiologists?
I think it's a great field to work in. I think we're now more and more focusing on what we call multimodality imaging. So that's in cardiology, certainly we have 4 big tracks, let's say. We have those of us who who want to do angiograms, cath, angioplasties, so interventional.
Nice.
We have electrophysiology, which takes care of, which is also an invasive strategy that deals with arrhythmias, with procedures, pacemakers, that type of thing. Mm-hmm. We have heart failure transplant. These are specialists for that population, for growing population. And then finally, what I do, non-invasive imaging. And more we are advising our trainees to be good in more than one modality, simply to increase your I think for me personally, I think MRs helped me become a better echocardiographer. And I think echo helped me understand MR better, although the physics has no common correlation to it. You have to start right from scratch.
Right.
I think that the heart is the heart. So if you look at it with ultrasound or with MR, and in the case of Clint, you look at it with CT and MR. So we come from different angles towards the MR, and I think that's what makes the strength of our team. I think you need to find you need to work and collaborate, and I think you need to build bridges with other professionals. You need to be collegiate about it, and I think it's the way the world should work.
Right.
That would be my take. That I think we need more collaboration, and I think cardiologists when they order, because often they're the ones with the patients, but there are other professionals that will order tests, internists and family practitioners that also may want to. But MR is kind of a very specialized tool, not a first line tool. I think it can help answer some questions about characterization, infarct, scar, flow. It's very flexible. It's got great added value, but it has a few Achilles heel. In particular, metal implants are a bit more of a problem than with CT. Understanding that patients with irregular heartbeats, older individuals who don't have the endurance to do breath holds may have a hard time with these. It's a test that takes a little bit of time. So when you prescribe an MRI, you have to tell the patient this is a longer test. This is physically more demanding. And even though we're doing our best to do it as quickly as we can, and you both know when you do it, you want to get this done efficiently. But it's a test that takes time, basically. It's but you get a lot of information out of it, and I think that would be so that would be my message for the trainee, and then for the practitioner. Understand what it does. understanding the strengths and weaknesses of CT, MR, ultrasound, and nuclear.
And
I think these are...
You bring up an excellent point too. The heart is the heart. And, it's amazing how many radiologists won't actually look at an echo.
Right.
It's an ultrasound of the heart, right?
They're so scary though. Huh?
Right. They throw all these numbers on there,
Right.
Half of them no one ever looks at, but MR is headed that way too. So,
right. That's true.
But the heart is the heart. And, I think that you should be able to recognize pathology on all these different modalities. It is a little bit tricky because the artifacts are different, and, they just have a different look and feel to them, but at the end of the day, it's still the heart. So don't be afraid to look at a nuke med, perfusion study, or to look at an echo, just for radiologists out there, because and obviously, number one, collaborate, talk to cardiologists. We are all allies in trying to take care of these patients, and give them, and get the information that people need to take care of them. And so, at the end of the day, what we do is take care of people and try to keep people well, or keep them well, or, so
get the best outcomes, right?
Yeah. And we all need to work together. So that's been one, I think, the biggest, the advancement in medicine over the past couple centuries has been, olden times, you had the one doc that did everything, right?
Yeah, exactly.
And now we have this subspecialized system. Now that there are downsides, because there are all these cooks in the kitchen, and the right hand might not know what the left hand is saying.
Right.
But if the left hand never asks the right hand what it's doing, of course it's not going to know, right? So we need to collate. And technology, I think, is going to play a role in helping us kind of communicate more.
For sure.
But we're all part of the same team, trying to do the same thing ultimately. So.
Well, cool. Well, thank you guys again.
We do like to wrap up every show with a couple questions. One, so basically, and we'll start left to right. So what has been the most satisfying or fulfilling experience you've had since starting your career in radiology?
Oh gosh,
it's loaded.
Yeah, that's
by the way, he was prepared. We did prepare him for this question.
Yeah, right. I mean, at the end of the day, what we're doing, like I said, is we're taking care of people.
Right.
And radiologists work very much behind the scenes. It's very rare to get any kind of feedback.
Right.
So on those rare cases where either a referring clinician or an actual patient reaches out and says, "Hey, this you figured something out that nobody else could figure out," or something. A lot of times it's an incidental finding, like 16-year-old girl with thyroid cancer, incidental finding, like a 34-year-old with breast cancer that somebody picked up. It's just feeling like I really directly contributed, because sometimes it's a slog, when you're looking through 100 ICU films, and
you get desensitized.
Yeah, right. But we do all make a difference, and so I would say the few instances where I actually get feedback from patients or from clinicians where they're grateful or thankful, to me that really brings things back into focus,
right?
Because I do work in a dark room without windows.
Right.
For you, Dr. Marcotte?
I think it's been, I've been a cardiologist for 30 years, and I've enjoyed every day. I mean,
nice.
For me, I come into work and it's not obviously you get a high when you diagnose something and you make a difference in a patient's life.
Stuff, yeah.
You agonize when you've missed something and you haven't been able to deliver. That happens. It happens more when you're young, but it happens at any time. So I try to stay humble. When I have a brief moment of victory, I enjoy it, but then you have to forget it.
Right.
And you have to get right back to work, because the next case is around the corner. And if you're not sharp and you think you've got it all made and you think you're like, ooh la la.
Yeah.
Boy, medicine has a way of reminding you that you are human, fallible, and you can make mistakes. So, so for me, it's been a great experience. I've worked in some great institutions. I've met some great people, patients, colleagues, nurses, technologists, And I guess for me, it's been the team, it's been the adventure. I think there's nothing that poisons a team more than people who don't work together.
Yeah.
And I think that the sad parts of my career would have been when I've had to work with individuals that didn't think as a team. And now, we all have our good days and our bad days, and we go through hardship. We go through, we each have our challenges, but I think it's trying to, once you enter the hospital, you have to say, I'm here to help. And, and that's it. But it's been a great, I feel very fortunate to have chosen this line of work. I'm really happy with my choice, and hopefully I can help people some more.
That's amazing.
And I would say my experience just being around you guys seem super enthused about what you do.
And it spreads like wildfire.
How nice is it to be able to do something that you actually like and want to do every day?
We're a minority for sure.
Yeah.
It's just so refreshing. Like I will say lately I've been getting more and more kind of administrative duties, you know, and it's just, that's not what I'm trying to do. That's not why I'm trying to do.
It's a long yawn, right? It's like, I guess this is a part
I would
of
rather
it.
just sit in the reading room and read cases all day, and like look at stuff. I don't want to be figuring that out. But you help however you can, because at the end of the day, that's important too. We're all taking care of people.
Yeah.
So you do what you can, but gosh, how lucky are we to be able to do. You brought up a good point too with the humility. It reminded me of you remember that movie Patton? It was about the general, George Patton.
Oh, yeah.
At the end, he's walking off. His big deal is he thought he was who knows, right? But he was a reincarnated Roman general. And he was talking about how during the Roman triumphs, the general would ride into Rome, with all these captured people in front of him. And there'd be a slave holding the laurels over his head, but the slave would be whispering into his ear, "All victory is fleeting," and it just, I thought that was, that just reminded me of, it's true, life is, there's ups and downs, and you always have to bring your A game and be ready to be humble. So.
Cool.
And we're surrounded by people who bring their A game every day. So we're
so
lucky to be working where we are, and they work with us. So thank you again for coming today.
Thanks for having me.
So I guess that's it for today's topic.
Yes,
Cardiac MRIs. Thank you for watching. Again. Thank you for subscribing. If you haven't subscribed, hit that subscribe button.
Yes.
Please leave comments. We read those comments. Give us show ideas. Give us questions. We're happy to answer them. We would love to have these two back sometime.
Yes.
So
just a wealth of knowledge, as you've already seen.
I cherish every moment I get.
We'll do it.
It's such a pleasure to work with these guys. It really is.
So I'm very lucky.
All righty, Zone 3 podcast. Thanks again for watching. We are out.
Thank you, guys.
Thanks, guys.
Yeah.